All right, everybody. I hope those of you were able to catch my live. If not, I did write that up a little bit. If not, I did put the replay up here on Facebook. But I am starting this little mini series as I am leading up to releasing my new free clinical guide. So I wanted to do kind of these little mini videos to try to help you guys get just get more confident and ready to take on clinical, because I know it is a huge change and a lot's going on. So we're going to kind of take things and break them down in little bite-sized pieces. So those of you who don't have my first slide, feel free to download that. This is one is going to kind of build off of that one. And then if you choose, you can unsubscribe if you want, but then you get added to my email list, and I share weekly, every Sunday I send an email. Well, most Sundays I send an email called the CRNA coffee chat. And I talk about all kinds of crazy things, all kinds of good stuff to help you guys get through the CRNA journey. So that's that. I will be releasing this new clinical guide very soon. Little things I'll be talking about is, so what happens when you get to the OR, right? We got to put the monitors on. We have to pre-oxygenate. We have to push the drugs. We have to manage the airway, right? We have to position. Then there's a timeout. Then there's fire prevention. Then we have to talk about thermoregulation. So I'm going to be talking about all those little things, give you guys like an introduction to that. And plus some of that stuff's going to be on board. So it's going to come get you later when you need to go and pass board. So yeah, so super excited about that. Plus I have some other announcements coming soon, but let's jump into today's topic, which is going to be documentation. And you will see all kinds of documentation, to a ton of documentation, to basically nothing. And everyone has their rationale. Everyone has their way of doing things. That's why you're in school, to learn all the things and then pick and choose what you like, what you want to keep and use in your own toolbox. So I am just going to go over a few key documentation things and give you some kind of nuggets that you guys can use as you are starting clinical. So pre-op. Pre-op, you must paint a picture of what that patient looks like before you touch them with drugs and before they are split open with surgery, okay? Basically, your document from pre-op to PACU is telling a story of the amazing anesthesia that you're given. So tell that story and, hopefully we can all stay out of court. Anyways, so what does the patient look like pre-op? What are their baseline vital signs? What are their baseline labs? What are some things in their history that you need to look at? If they have a history of heart failure, when were they hospitalized last? Are they short of breath at baseline? If they have COPD, are they on oxygen? What's their activity like? Can they walk a block? Can they go up some stairs? Diabetics or neuropathies, where are their neuropathies at? Are their feet, can they feel anything in their feet? People's range of motion that have had surgeries or injuries, can they move their joints? What does that look like? What does their back look like? How does their neck, if you lay them down, do they need like 20 pillows on their back? So and then strokes, which side are they weak on? Look at those strengths, test those strengths pre-op, because you never know what could happen in the OR and you must be prepared for everything. So just make sure, no matter what you are doing, head to toe, you are looking at every piece of that patient. What do they look like before you touch them with drugs, and document that stuff and ask the questions, okay? And trust me, guys, I got resources coming, so don't worry about all the minutia. I got stuff for you guys. Intraoperatively, right? So now we've got a picture of them pre-op. Now we are going to bring them into the OR and we are going to put them to sleep and manage their anesthetic while they receive surgery. So things to note in your documentation. I always throw, standard ASA monitors were applied on the patient. You get the patient in the room, you've got your baseline vitals. You always want to get a set of baseline vitals and make sure to check that rhythm. What is that rhythm before you've given them drugs? Because trust me, I pushed some drugs and things that went down, and so pay attention to that. And also, you also want to check out their baseline EKG if applicable pre-op. So you get them in the room, put your monitors on. And then you have to do like an airway note, right? The key with your airway note, if you're manipulating, if you're doing like an LMA or if you're doing an ET tube, atraumatic. Was it an atraumatic intubation? What was your view like? What was the equipment that you used? Where did you leave your tube at the lip? All those things are super important because they also might be used later. Or, did you have to mask them with a 10, 100 airway, 100 milli airway or 10? Because they, their tongue fell back, whatever. Oxygen devices used. Did you use a face mask? Did you use a nasal cannula? Did you use a face mask with an oral airway? All those things are important so that if they come back, you can guide other people in how to care for these patients as well, as far as what worked. After you get your airway notes, and even LMAs, atraumatic placement of the LMA. Okay, super important. Make dentition intact. I always put a note, no change in dentition intact, but of course, unless something happened, but for the most part, baseline dentition intact. Okay. So those are some key things to get in your documentation. Positioning, head and neck, right? Are the head and neck neutral? If not, if you're doing some type of neck surgery, I'll even put surgeon positioned, head and neck hyperextended, right? Padded. What's under their head? A pillow, a donut. Brachial plexus. You have to talk about the brachial plexus. You have to make sure that you are not stretching the brachial plexus in any shape or form. So things like bilateral arms on arm boards, padded, less than 90 degrees abduction, supinate, you want to keep those arms supinated. If arms are tucked, you want the thumbs up. If they're doing prone, like a prone head pillow, like prone pillow used, no pressure to eyes, no pressure to chin, no pressure to nose. If you're positioning them lateral, make sure like the ear isn't folded over, the eye isn't like smushed, right? Eyes, tape the eyes if applicable, or show that you protected the eyes if you're doing like a MAC case. Okay, so key things you have to look out for. Trying to think, I've made little notes, I didn't forget anything. Basically, you want to write like all pressure points padded. Make sure you're looking full scale, because these patients cannot tell you if their finger is like stuffed, their arm fell off the table, etc. So positioning is a team effort, should be with the surgeon or the PA, whoever's in there, the nurses, team effort on positioning the patient correctly. Let's see here. And then, so after you get them positioned, then it's basically about maintenance, right? So documenting your train of 4, if applicable, saturations, what rhythm they're in, their vital signs, their heart rate, their blood pressure, end tidal, the end tidal of SIBO or the gases you're using, what medications are you titrating in, what are their fluids, keeping an eye over the drapes, always look over the drapes, what's happening over there, what's my blood loss looking like, right? And then you're just keeping a record of everything that you are kind of tweaking and doing throughout your case, okay? Then emergence, so keys for emergence. Yes, you can kind of write all extubation criteria met, etc. If you have a tube in place, and unless you do it deep, I did write, there is a post on deep versus awake extubation, but unless you do it deep, you need to show on that piece of paper that patient was ready to be extubated. So did they have 4 out of 4, train of 4 with no fade? Were they either have sustained head lift greater than 5 seconds? Did they have, a 5 out of 5, hand grip strength? Does the patient open eyes to their names? Are they following commands, right? All the things, what are their tidal volumes? How are their tidal volumes? How their respiratory rate? Show me on that documentation that they are ready to be extubated, right? And then the next piece of that is handoff. Okay. So now we're going to get them to PACU, paint that picture for me. What does that patient look like now? So now they're extubated, or the LMA is removed, or we stop giving all the ketamine and prop and all the goods for a MAC case. So I always like to see, vital signs stable. I took them to recovery. I got a great temp. They're like at least, 97, 98, rocking it out. Are they back at their baseline? Are they mentating? Do, ANO times 3, a little sedated, but are they able, like, can you tell they're back at their baseline? They don't look off. State that you handed off care, report to receiving RN. Respiratory rate, stuff like that, your set of vitals. So make sure you are documenting every piece of the puzzle, all those little things that I kind of talked about, the positioning keys, the airway keys, emergence, and then handoff, because it's so super important to paint that picture, not only to protect yourself, should something happen, but also to give other people a picture of what this patient looked like under anesthesia. So they can look up your record and be able to give a safe anesthetic like you did. Okay. So those are my documentation tidbits. There will be a little bit of documentation stuff in that guide. So stay tuned. I've got tons more coming. And if you guys have any questions, please let me know. Okay. See ya.